Testing for troponin levels in patients with suspected acute coronary syndromes is a tool we all use, especially in the emergency room. In JACC, there is a review of troponin release after exercise, a novel concept, but one that is real. The use of highly specific troponin assays, coupled with the possibility that prolonged or strenuous physical activity, such as marathon running, might be harmful to the myocardium, has led to numerous studies documenting release of troponin after exercise. Most of the studies are in healthy individuals, but there is no doubt that strenuous exercise can cause a troponin rise. For example, in non-elite athletes competing in the Boston Marathon in under 4 hours, only 13% of those studied had troponin levels greater than 0.1 micrograms per liter, but the rise is clearly not high. The authors conclude that the troponin release is likely a benign process. For patients being evaluated for the possibility of an acute coronary syndrome, physicians should be aware that exercise stimulates troponin release, and they need to include a recent history of physical activity in making clinical decisions. I'm Peter Block with a CardioSource Heart Minute.
I'm Mike Contos, CardioSource editor for Biomarkers. I'll be discussing a recent article from the June issue of American Heart Journal. Because troponin is released in the bloodstream soon after myocardial injury, it is used as a specific biomarker for myocardial necrosis and now is considered the gold standard for diagnosing myocardial infarction. Interestingly, prior studies have demonstrated that a minority of patients who are asymptomatic and who are clinically stable have detectable troponin, raising the possibility that these patients have ongoing subclinical myocardial injury. Prior studies have demonstrated that these minor troponin elevations are correlated with underlying cardiac pathology, such as left ventricular hypertrophy, coronary artery calcification, and heart failure, and they also appear to have prognostic value as they predict cardiac death during follow-up. Now, newer, more sensitive troponin assays have been developed that have even greater sensitivity for detecting very low troponin concentrations. It should be recognized that the term high sensitivity is somewhat of a misnomer, as most of the currently available assays have both high sensitivity and specificity compared to older assays. In their study, published in the June issue of American Heart Journal, 1,072 Japanese men undergoing an annual company medical exam were included. Subjects were excluded who had a history of coronary disease or were undergoing hemodialysis. All subjects were administered a questionnaire that was used to collect the subject's health habits, risk factors. An ECG was recorded, and blood samples were collected. A number of laboratory values were measured, including a complete lipid profile and both standard and high sensitivity troponin T. There were a number of interesting findings in this study. First, in contrast to other population-level studies, which detected troponin in less than 10% of patients, the investigators found that 81% of the subjects had detectable troponin, although the values were low, with a median value of only 4 picograms per milliliter. In contrast, no subjects had detectable troponin T when measured using the conventional 4th-generation assay. Similar to prior studies, patients with detectable troponin T were older and had more risk factors. Using multivariate analysis, age, systolic blood pressure, estimated glomerular filtration rate, smoking, and left ventricular hypertrophy were indeterminates of detectable troponin. Another interesting finding is that the highest tertile of troponin values had a significantly increased likelihood of having a high 20-year estimated risk of cardiovascular disease using the Framingham risk equation. It is possible that these elevations relate to coronary microvascular dysfunction, increased wall stress, and/or decreased subendocardial coronary blood flow, which may cause small amounts of myocardial cell necrosis, apoptosis, or cellular membrane leaking, leading to detectable troponin values. These findings raise the possibility that the evaluation of minute myocardial injury, in addition to low-grade systemic inflammation, may improve the ability to estimate risk for use for primary cardiovascular disease prevention. Given the ability to detect troponin in such a high proportion of asymptomatic, clinically stable patients, Prospective studies are needed to determine the clinical meaningful cutoff value of troponin in the general population. Studies like this should also increase our awareness that troponin elevation should not be synonymous with acute coronary syndrome, and a single elevation out of context with the clinical scenario is insufficient to identify myocardial infarction. Hello, I'm Mike Contos, the CardioSource Editor-in-Chief for the Cardiac Biomarkers community. Cardiovascular risk assessment based on classic risk factors does not fully predict subsequent risk, which has led to a number of studies exploring the value of adding biomarkers for improving this risk assessment. Probably the best known example is C-reactive protein, which has been incorporated into the Reynolds risk score. However, other studies have found varied results, with some showing biomarkers added no additional predictive ability. Some of the variation in study results derives from differences in the number of patients included, the number of events that occurred, and variations in the biomarkers assessed. To address this, in one of the most extensive studies performed thus far, Blankenberg and colleagues tested 30 different biomarkers to see which, if any, were useful for predicting cardiovascular events. In their study, almost 10,000 individuals were included from 2 different European cohorts. Importantly, patients with known coronary disease were excluded. Patients were separated into a test and derivation cohort, and the ability of the different biomarkers to predict events in the subsequent 10 years was evaluated. The 30 biomarkers that were evaluated represented markers from 9 different categories, including lipid metabolism, inflammation, ventricular stretch, vascular function, oxidative stress, coagulation, renal function, angiogenesis, and myocardial necrosis. The authors found that a number of the biomarkers were significantly correlated with outcomes. After accounting for numerous baseline risk factors, including those included in the Framingham risk score, 3 biomarkers emerged as having the strongest predictive value, all of which reflected different pathophysiologic pathways for cardiovascular disease. Importantly, all are currently available and standard markers in use. These included NT-proBNP, a marker of ventricular stretch, C-reactive protein, a marker of inflammation, and troponin I, a marker of necrosis. Interestingly, these 3 markers were better predictors than any of the newer, more novel biomarkers. In an additional analysis incorporating the 3 biomarkers into a composite biomarker score that also included clinical variables, it significantly improved the ability to predict events over clinical variables alone. This study adds to prior ones indicating that biomarkers have the potential to improve the risk assessment of an individual patient. Subsequent studies will need to address whether this additional predictive ability is worth the cost and determine whether age and gender cutoffs improve their predictive ability. In addition, a key question is defining which, if any, treatments aimed at reducing the biomarkers also reduces patient risk and improves outcomes.